Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Factor Xa inhibitors are direct-acting oral anticoagulants that inhibit free factor Xa to decrease thrombin generation and clot formation. The first factor Xa inhibitor was FDA approved in 2011, and millions of people in the U.S. receive a direct-acting oral anticoagulant annually. Initially approved for stroke prevention in non-valvular atrial fibrillation, factor Xa inhibitors have gained approval for numerous additional indications. All anticoagulants carry a risk of bleeding. In the setting of major bleeding, urgent reversal is often necessary. Prothrombin complex concentrates, PCCs, are frequently used off-label for reversal of factor Xa inhibitor-associated major bleeding. Accelerated approval was granted for andexanet alfa, a specific factor Xa inhibitor reversal agent, in 2018 for reversal of the factor Xa inhibitors apixaban and rivaroxaban when reversal of anticoagulation is needed due to life-threatening or uncontrolled bleeding. Following accelerated approval, some clinical practice guidelines were updated to include recommendations for andexanet alfa preferentially versus PCC for reversal of life-threatening or uncontrolled bleeding due to rivaroxaban or apixaban. Other guidelines stated no preference of andexanet alfa versus PCC. Vizient convened expert panels in 2020 and 2024 to critically appraise the literature and provide consensus-based expert opinions on the utilization of pharmacological reversal agents for factor Xa inhibitor-related major bleeding. We're excited to welcome Dr. Lisa Baumann-Kreitziger, Associate Professor of Hematology and Oncology, Medical College of Wisconsin, and Medical Director of the Antithrombotic Therapy Management Program at Froedtert Health, to discuss the current status of management of factor Xa inhibitor-associated major bleeding. I'm Dr. Carrie Schwartz, Senior Clinical Manager of Evidence-Based Medicine and Outcomes with the Vizient Center for Pharmacy Practice Excellence, and your program host. Welcome to the program, Dr. Baumann-Kreitziger. Let's start out with discussing the current state of hemostatic management in the setting of factor Xa inhibitor-related major bleeding.
We really have two options for management. We have our prothrombin complex concentrates, which are vitamin K-dependent proteins that are in a concentrate. And then we have andexanet alfa. There are pros and cons of each of these medications. For prothrombin complex concentrates, or PCCs, they are easy to mix, they are very readily available, and they're less expensive than our alternative. A couple of cons of PCCs are that it does not change the anti-10A level. So this is important for providers to know, because if you check an anti-10A level after administration of PCC, it will not be different. That does not mean that you should give an additional dose of PCC for those patients. Secondly, PCC is not FDA approved for management of hemorrhage in patients receiving DOAC, but it is FDA approved for management of warfarin-associated hemorrhage. This is a problem sometimes because people then may do that testing and wonder why it hasn't changed after administration. Andexanet alfa, on the other hand, has accelerated FDA approval, and we'll talk about that in detail later. It will give you basically 4 hours of low anti-10A levels. The cons to andexanet alfa, though, are it's harder to mix, it is more expensive, and therefore less readily available within the United States. There is significant variability in practice between institutions and some pretty strong opinions about which agent should be used. Each institution has been and will need to continue to evaluate how to manage these critically bleeding patients and take into consideration not only the cost of the agents, but also the clinical impact to that.
Lots of decision points here to consider. One of the reasons clinical practice and formulary decision-making is so challenging here is what evidence has been available up until recently. Can you comment on that?
Yeah, so accelerated approval for andexanet alfa was based on surrogate endpoint changes of that anti-10A activity. We also have prospective cohorts and multiple administrative claims database studies, but most of the data there are retrospective and meta-analyses of those retrospective cohorts. The problem with that data is that there is specific decisions why one agent is used versus another. So even within an institution, algorithms may be in place where certain medications are used for specific patients, and administrative claims database or even statistical correction for those can't correct for those underlying differences between patients. So there is a lot of bias within those retrospective analyses. And up until recently, while we didn't have randomized controlled trial data with clinical outcomes. And that's what we'll be able to discuss coming up.
Yes, exactly. These studies were just plagued by confounding by indication. And then came the publication of the much anticipated ANNEXa-I trial in May 2024. This was the confirmatory trial with clinical outcomes of hemostasis for continued or full traditional FDA approval of andexanet alfa. ANNEXa-I compared andexanet alfa to usual care. So it is not a direct comparison to one agent, but usual care, which is defined as the care at the discretion of the local provider. However, in usual care, 85% of patients in this group received prothrombin complex concentrate within 3 hours. And this study was conducted in patients with intracerebral hemorrhage. This was due to a protocol change. It was originally intracranial hemorrhage, but switched to intracerebral hemorrhage during the conduct of the trial. So hemostatic efficacy was a composite endpoint of hematoma volume change, National Institutes of Health stroke severity score, and no receipt of rescue therapy up to 12 hours. Significantly more patients in the andexanet alfa group as compared with usual care. That was about 67% in the andexanet alfa group, and 53% of patients in the usual care group achieved hemostatic efficacy. This was largely driven by larger reductions in hematoma volume in the andexanet alfa group, as there were no significant differences in NIHSS score, National Institutes of Health stroke severity score, or receipt of rescue therapy. Significantly more patients in the andexanet alfa group experienced at least one thrombotic event, 10.3%, versus 5.6% in the usual care group. There were no differences in mortality that reached statistical significance. Neurologic status and long-term functional outcomes were not reported in the publication of ANNEXa-I. So Lisa, what's your take on this?
Like many studies, including this one, there were mixed results. The primary endpoint was driven by a decrease in hematoma expansion, which is important because hematoma expansion has been correlated to functional outcomes and mortality in other prior studies. Some of us were concerned about the composite outcome being driven by the rescue therapy, but the trial results did show us that the primary endpoint was driven by hematoma expansion. And the results of that held up in all of our subgroup analyses, including when the analysis was restricted to only those receiving PCCs. Because that was another concern of the trial design, is that if many patients in the usual care arm didn't receive PCC, it was not then a true comparison between andexanet alfa and PCC. But the subgroup analysis did have the same results. Now, the thrombosis rates were concerning, and there was a lot of questions then when this came out about how to understand those thrombotic events, the timing in which they occurred, and if they could be mitigated by anticoagulation, because that's what was shown in previous studies of use of andexanet. The issue with mortality was also brought up, is that there was a lack of translation of the hemostatic efficacy to a mortality outcome. Granted, the study wasn't powered for mortality, so it would have needed to be much larger if that was the purpose.
Yes, and just like any good trial, ANNEXa-I also generated hypotheses. Even after this trial, we were still left with knowledge gaps that were a central part of the debate when the Vizient panel reconvened after publication of ANNEXa-I.
Yeah, there was a lot of questions that we had and looked at what was the clinical outcome and the relevance of that time frame of 4 hours of not having anti-10A activity. We saw that there was a decrease in hematoma expansion, but had a lot of questions regarding if that correlated to functional outcomes for patients. Did people in one category or another recover faster to a better functional state? Of course, there were questions about mortality, the timing of the thromboembolic events, and trying to understand if we could use anticoagulation to mitigate that. There were some questions if the time point went out to 30 days, if the thrombotic events occurred late in that time frame in patients that just weren't started on anticoagulation, then people would be less concerned about the use of ANNEXa-I. If the thrombotic events would have occurred late in the 30-day interval that was being measured in the study, then providers would have been less concerned about the use of andexanet alfa because they could have started anticoagulation in that time frame. The other piece is that we need to understand how to apply the trial data to areas outside of intracerebral hemorrhage, which is what was studied in the andexanet-I study, to GI bleeds or other areas as well.
And many of the points that you bring up that were deliberated in the panel were also points that many other people had questions about. And later on, in November 2024, the Food and Drug Administration, FDA, convened an advisory committee, an AdCom, to discuss many of these points. Whether the treatment effect on the study's primary efficacy endpoint constitutes a clinical benefit to patients. It's important to note additional data was presented in the AdCom meeting that was not reported in the ANNEXa-I results published in May. The committee was asked to consider if an effect on hematoma volume change at 12 hours alone constitutes clinical benefit, should neurologic status at 24 hours, functional outcomes at 30 days, mortality, and anti-10A reduction be a part of the assessment of andexanet alfa. The AdCom was also asked if the serious risks of andexanet reported in ANNEXa-I are acceptable in the indicated population and in the context of the clinical efficacy demonstrated in ANNEXa-I.
The AdCom data was enlightening and really answered a lot of the additional questions that the panel had when we met. First, with the timing of the thromboembolic events. The median time to a clot in the andexanet arm was 3.5 days and ranged from 1 to 4 days versus a median of 16 days in the usual care arm. These events happened early in the disease course and in a time frame in which anticoagulation would not be restarted in the setting of a bleed. Additionally, of the 35 andexanet-treated patients who had a thrombotic event, 18 of those, or 53%, had a thromboembolic event within those first 3 days, compared to 1 of the 16 patients in the usual care group. It was a significant difference of timing of the thromboembolic event. What we did also hear about was the restart of anticoagulation. Prophylactic anticoagulation was restarted in about 70% of patients in the study, and 9.5% of people had a thrombotic event with andexanet alfa were restarted on anticoagulants or at least received 1 dose of a prophylactic anticoagulant versus 5.5 in the usual care arm. Of those who didn't receive a prophylactic anticoagulant, 26% experienced thrombosis in patients who had andexanet versus 10% in the usual care arm. It does show us that anticoagulation doesn't, unfortunately, help mitigate as much as we anticipated or hoped it would. Lastly, functional outcomes were really similar between the groups. What we also learned is that most patients presented in a moderate to severe disability status within the study. No matter what we do with reversal of anticoagulation, what this showed us is that most patients present with the disability that they are unfortunately going to continue to have. So it's important for us to prevent bleeding in the first place instead of only worry more about how to handle it once it happens.
Functional status and functional outcomes, those are those important patient-centered outcomes that patients and families and caregivers are most interested in, especially in the long term.
And moderate to severe means that you have to have somebody else help you function. And that's what people want to prevent and not be a burden on their family or be able to live independently. So I agree with you that although this was presented later, it really shows the community again that these really should be incorporated in the initial publication because that's what patients really are worried about.
Absolutely. On that note, shortly after the AdCom convened, FDA issued a complete response letter, a CRL, that andexanet alfa would not receive full approval. And to this day, it remains in an accelerated approval status. We're in a holding pattern. What can we talk about and how can we approach clinical management of patients and formulary decision-making in the current state?
We're all in limbo, honestly, and each institution has to weigh the data from both the andexanet-I and the new data from the AdCom panel to inform their formulary decision making in their clinical practice. It's unknown when we're going to hear from the FDA one way or another, if additional data is going to be requested from another study, or if the drug will be removed from the market from the manufacturer. But until one of those things occurs, each institution needs to look at what their current practice is and identify if this changes that practice. There definitely are institutions where PCC is their standard of care, and the data will likely not change that recommendation or that opinion of those institutions. The institutions that use andexanet more frequently will need to determine if the thrombotic events will modify the patient populations that they use andexanet alpha for, or the approach to anticoagulation in those settings may also change as well.
Yeah, it's definitely a balance between treating the patient in that immediate critical period and thinking about the long-term outcomes as well. We should all be vigilant and continue to look for additional data and literature, as well as any regulatory actions regarding andexanet alpha. This is definitely to be continued.
Join us for more Verified RX podcasts. Subscribe today. Like us. Send us your comments. We'd love to hear from you. Verified RX is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.